Welcome to Let's Talk Death, conversations to inform and inspire. Let's Talk Death is a series of conversations with some amazing people from various fields. Our goal through these conversations is to normalize, educate, and demystify the taboo around death, dying, and the journey of grief. Hello, welcome to this episode of Let's Talk Death. I'm Fran Solomon.
And I'm Andy McNeil.
And we're thrilled to be your hosts for these conversations. Let's Talk Death is brought to you by Heal Grief, a social support network creating community after someone has died. Everything we do is inspired by our core belief that no one should ever grieve alone.
Our goal with this program is to have a friendly chat with some amazing people in the field so we can help normalize and educate our Heal Grief community. Our guest today is Dr. Santosh Kesari. Dr. Kesari is a board-certified neurologist and neuro-oncologist and is currently chair and professor of the Department of Translational Neurosciences and Neurotherapeutics at St. John's Cancer Institute. Dr. Kesari is ranked among the top 1% of neuro-oncologists and neurologists in the nation, and an internationally recognized scientist and clinician. He has a long-standing interest in cancer stem cells and studies their role in the formation of brain tumors and resistance to treatment. He believes that in order to cure patients with brain tumors, we first need to gain a better molecular and biological understanding of the disease. A physician scientist, Dr. Kesari harnesses his experience in surgery, chemotherapy, immunotherapy, radiation therapy, and novel devices to help develop precision therapeutic strategies that will advance medicine to a new stage in the battle against brain tumors and eradicate the disease. Dr. Kesari, we are delighted to have you as a guest on our show.
Thank you, Andy. Thank you, Fran, for inviting me to be here.
Of course. So, Doctor, you have many more achievements, and we're going to be posting them on our website. However, I'd like to focus on something more personal, your compassion for your patients and their families, too. Was there a death loss in your life that may have deepened your empathy as you journey with them?
Yes, I mean, as an oncologist, and in particular for such a deadly disease as brain tumors, we tend to get very close to our patients and the caregivers of our patients. So every patient is like a family member when we lose them. And having done this for 20 years now, it's been a long road and a lot of losses over the years. But I've learned a lot from every single patient on how to do it better in terms of treatments, but also how to understand living and dying and how to think about it better and how to explain it to patients and family members better too. But I personally have, it's actually my mom's first year anniversary of death. She died last April 10th from cancer as well. And I've lost several other family members to cancer actually in the last few years, and also COVID actually in the last year. We've had at least 3 family members outside the U.S. Died of COVID. So it's been quite a troubling year, and past few years of having to personally deal with all the losses.
Yeah, and you're still so very young in your journey as well, with your mother.
Yeah. I will say, when you mentioned your mother and it's the 1 year anniversary, I had the 13th year anniversary of my mother's death from cancer on the 11th of this month. So
yeah.
Very difficult time. So let's talk more about your work. I mean, you're cutting edge on so many fronts.
Yeah, so, one of the things, the way I think about cancer kind of gives you a timeline like that you weren't thinking about before. And for all of our patients, what we try to do is extend survival, but extend quality as well. And then kind of give a a chance for patients to understand what life is all about and to reprioritize things and help them reprioritize. So it's a journey that we're all taking, and there's a timeline for this journey for most of my patients because it's such a deadly disease. Not that we talk about it, death all the time, but that we're keenly aware of that possibility more than before the diagnosis. And then we, like I said, try to prioritize the things that are important, as well as manage the medical side in terms of, doing cutting edge clinical trials, research. We try to really do precision medicine in the sense of understanding the tumor, what makes it tick, and can we find a drug that will help the patient, whether it's part of the trial or whether we can get it off-label through drugs that are already approved on the market. So we are quite aggressive and wanting to help patients, wanting to really test these drugs that are out there that are not going to make it for these patients anytime soon in terms of clinical trials. So we try to get them access to these drugs that could help. And there's various ways to do it. It's called expanded access, compassionate use, and more recently, right to try, or single patient clinical trial. So there are various mechanisms that we work on to try to get patients access to new treatments.
So you said something that really brought into my next question. There's usually a fine line between offering hope versus a realistic outcome of the disease. And we all know that hope is an essential part of wellness, but yet we hear so many patients or family members say, if only I knew that that was the only time I had left. So where is that fine line for someone who doesn't have a good prognosis and will probably die?
Yeah, that's a very good question. And, that's something I struggle with all the time in terms of how to present it. But actually, every patient, family members have their own expectations or perceptions or wanting to know details versus not wanting to know details. So at the initial visit, I really kind of asked the question, how much do you know about the disease, prognosis? Do you have questions for me? Do you want to know more? And some people do want the hard numbers, although the numbers are averages. We can't specifically say you're going to live X number of months or years. It's an average estimate. And so it's surprising. I would say more than 50% actually don't want to know the number. Like you have 1 year to live or 2 years to live. It may sound surprising, but that's in reality what they just want to trust the physician and the team that we're going to do our best. I think they do have some idea, even though we don't talk about it, because it's all over the web. The family members know too, to a great extent. But it's like we know it's bad. We know it's not 5-10 years, but we just want to stay positive and let's go through the treatments and what you're recommending. So it is very individualized, the discussion and how much information they want to know, how much information to give, and how to give it as well while maintaining semblance of hope and positivity so that we can move forward on the treatments that will help, the current treatments as well as new clinical trials. So I may be overly optimistic because that we are research-based, we are trying new things, and we are optimistic.
Yeah, which I'm glad you're optimistic, and I'm glad you're on the cutting edge of this because you know more than we do. You're the one working with these patients with families, and you've walked this journey with so many of them. You more than any of us, I'm sure, are passionate about indeed finding that answer. That will extend life further, or for your patients. So I get that. I also appreciate just hearing your approach. Really following the lead of the family. There are nuances in conversations that I think help us to understand what people want and where they are. And isn't that part of walking with people, is paying attention to those pieces so that, in a lot of ways, like you said, you sort of do become like family during that journey. I'm curious if there are things when you first started into this, or maybe it could still be even now, that surprised you about the patients and families, that you work with, or just something that you came in, you knew after doing it that you weren't so sure about prior to getting into it.
Well, I think one of the things I learned early on, like there are some patients who want to fight till the very end, and even when the patient is not so strong or reversible in terms of the quality and everything that's going on, but the family members want to fight to the extent that they, sorry, to the extent that, statements such as, I can't live without my spouse. What would I do? Some have even, expressed not wanting to live anymore if the spouse dies. So in those very difficult situations, obviously we get psychiatry, social workers, psychosocial oncology involved, but even though caregivers feel like, that, it's amazing how when the person does pass, that they're resilient and change, and those thoughts that they had, while real and strong, once it's accepted, the patient passed, the caregivers become very resilient and, start a new life and never forget their loved ones, but are resilient and surprisingly stronger than I expected from what I was thinking before, needing a lot of support to get them through this period.
Yeah, it's funny. It's not real until you're there. You anticipate it and you have all these fears and things that happen. I've had people over the years that they describe it to me. They say, I woke up the next morning and the sun came up and I put my feet on the floor and and people were continuing with their life. And I just, in my mind, all that would end when this person dies. And so I think part of it is kind of life propels us to get up and to go and to continue being part of life, even though they're not saying there's not struggle and people don't, walk a journey there and it's difficult and it's individual for everyone. But to your point, I've heard that's what people have described to me is that, I realize now that my life will continue on. I just have to discover what will it be now?
Yeah.
As I'm told.
Exactly. Yeah.
So, glioblastoma, we have a lot of community members actually who have lost a loved one to the disease. What's coming in the future that is hopeful? Is there something that you can identify today that is hopeful?
Yeah. Yes, one of the challenges and opportunities is the fact that we've learned a lot over the last decade about all cancers, but in particular brain tumors, about what drives the tumors. We've learned that it's the disease is different in every patient. It's very genetically different. And the great thing is there are many drugs that have been developed in the last decade that target those mutations. And then really immunotherapy, the drugs that stimulate the immune systems, personalized vaccines have really developed quite well in the last decade, helping many, many other cancer patients. We have all this information, all this knowledge now, and we're learning that, it's not simply calling it glioblastoma or brain tumor, but that it's glioblastoma with all these mutations, all these immune markers, and now we have drugs also. So it's really exciting because we can put all this information together because it's going to be personalized. The reason we haven't made much progress is we're not tailoring treatment for each patient. We take a drug that's made or approved for something else, and we just try it in glioblastoma, and surprise, it works in a small percentage of patients. But if we were smarter and used all the data at our hands and actually picked the drugs for each patient, making them really almost single patient clinical trials, because that's how different everyone is. They all have different mutations. But So we have an approach that we've developed in the last 3 years called precision immunotherapy in the neoadjuvant setting, PIN study for short, PIN. And the idea is really to tailor the targeted therapies and immunotherapies and combinations in clinical trial for each patient, and also to do it early on in the game, not when the tumor comes back after radiation and chemo, but at the initial diagnosis. I think the reason we haven't made much progress in the past is that we've tried drugs after recurrence and nothing seems to work. Nothing seems to shift the curve to the right of survival. But maybe if we started in the beginning with, one or more drugs, even before radiation and chemo, maybe we can shift the whole curve of survival to the right, which is improved survival. And so we've treated patients in the last 3 years using that approach, and we've seen some pretty remarkable responses. Small percentages, but and it's a small study, so I don't want to overstate it. But we have 3 patients almost 3 years out without having to do radiation or chemotherapy out of about 20 patients. So it's small percentages, but each person's different. We looked at the data and we think we know why these particular patients responded so well and are doing so well in avoiding radiation right now. And so what we want to do is, from this approach, is to build upon more buckets of patients that have different mutations and put in combinations of drugs that would help increase from a 10% response to 20, 30, 40% response over time. So that's really personalized medicine at best. And that is really the future of medicine, whether it's cancer or dementia or heart disease. All these drugs that we have help really a percentage of patients, whether it's 5%, 10%, 50% of patients. So I think, and the tools and technologies and the drugs that are on the market help us really interrogate the disease, monitor the disease better, and treat the disease with these new drugs. We just have to put it all together. That makes it easy and faster for patients to get access and to try these sort of N-of-1 clinical trials. And I've been working within our institution and also within our network of hospitals in Providence to do this faster, but also with a lot of external collaborators and foundations and companies. In particular, a company called XCures, which I'm helping them design this for any patient around the country, so that we can really, the other hard thing, even in California, in my one hospital, we have patients driving 3-4 hours, and talk about travel burden and financial burden and all these other things. That is a big burden. And so what we've done instead is our program, we've gone to the community hospitals and set up shop at these other hospitals in Orange County and in LA County, so that patients don't have to travel all the way to Santa Monica, and they can get clinical trials and access to various other treatments. I'd like to do that nationally, and that's what XCures is helping us do, so that we could provide research level care anywhere in the country and access to these drugs, which is really what's needed.
Yeah.
Amazing.
Dr. Kesari, I'm sitting here, actually, I'll be honest, feeling a little bit emotional as you're sharing, because that is hopeful. It is hopeful, and I'm so grateful for physicians like you who have your eye on this and you're focused in on how do we treat this in patients, and seeing them as individuals and recognizing the nuances that's all part of this. So I just have to say, you've lifted my spirits and given me hope just in this conversation. I know that we still have a ways to go, but it's so wonderful to hear that even just those three patients, those 3 families, and what that means to them. So
what a difference in their lives.
Yeah, very much so. So we actually we're right at about the end of our time together. But before we ended, many people who chime in and listen in to our show are curious about how they can connect with our guests. So I wonder if there's a way that people could connect with you, with your work. How might they go about doing that?
Yeah, I mean, if you search my name, you'll find the link to our clinic. There is a general email, neuro.oncology@jwci.org, or our office number, 310-829-8265 is probably the best way to get there.
Great. Doctor, thank you. And we'll have all that on our website as well. We want to thank you again for being a guest here on Let's Talk Death and for sharing your personal story and all the great work that you're doing. Thank you.
Well, thank you for inviting me, Des.
We also want to thank those who are joining us for this episode of Let's Talk Death. If you would like to learn more about Heal Grief, please visit us at healgrief.org. At healgrief.org, you can learn more about all of the programs and resources of Heal Grief, including our national network of support for grieving young adults, a program called Actively Moving Forward.
And if you know a bereaved adult, refer them to the AMF app, where adults of all ages connect with others experiencing a similar death loss. And last, make sure you sign up on healgrief.org to receive our newsletter for links to future episodes of Let's Talk Death.
And so with that, again, thank you for joining us, and we will see you next time on Let's Talk Death.